So, so we are discussing hematological disorders, Chapter 23, bone marrow failure syndromes. Continuing with the next. Bone marrow failure, also known as aplastic anemia, is a rare condition characterized by reduction or absence of all three main blood cell lineages in the bone marrow. Red cell lineage, white blood cells, and thyrocyte presence, leading to peripheral blood pancytopenia. It may be inherited required. The required cases may be due to viruses, especially hepatitis viruses, drugs such as formamide chemotherapy, or toxins such as benzene, glue. However, many cases are labeled as idiopathic because a specific cause cannot be identified. Bone marrow failure may be partial, complete. It may start as phase of single lineage, but progress to involve all three cell lines. The clinical presentation is with anemia due to reduced red cell number, infection due to reduced white cell number, especially neutrophils, and bruising DNA due to thrombocytopenia. Inherited aplastic anemia, this is also all rare. Fanconi anemia is, very important. This is the most important of the rare inherited aplastic anemias. It also recessive. They are caused by mutations in one of the many fancy genes. Most commonly FANCA, FANCA, and the majority of children have congenital anomalies, including short stature, abdominal radii, and thumbs, renal malformation, malophthalmia, and pigmented skin lesions. Children may present with one or more of these anomalies as a sign of bone marrow failure, do not usually become apparent until the age of 5-6 years. Diagnosis is made by demonstrating increased chromosome linkage of full blood lymphocytes and or by genetic analysis on fancy genes to identify the causative mutation. This test can be used to identify affected family members or for prenatal diagnosis. Affected children are at risk of leukemia. The recommended treatment for transplantation using normal donor marrow from an unaffected sibling, unmatched, unrelated marrow donor. Schutzmann, Diamond syndrome, I hope I'm pronouncing it right. I don't know. This is autosomal recessive disorder. Characterized bone marrow failure together with signs of pancreatic, exocrine failure, hepatic insufficiency, and skeletal abnormalities, skeleton and pancreas, also caused by mutations in the species gene, which can be used for identifying unusual cases. Most children have an isolated neutropenia or mild pancytopenia like pancytopenia. There is an increased risk of transform into acute leukemia, so both can transform into acute and later in life. The disorder normal metastasis mystery describe the normal process by which blood coagulation initiated and terminate in a tightly regulated manner. This is to ensure the blood vessel wall injuries are rapidly repaired and resulting clot is contained within the area of vessel wall injury takes place, while a series of interaction involving cellular and plasma factor. There are 5 main components. Coagulation factors are produced mainly by the liver in an inactive form and are activated when coagulation initiated, usually by tissue factor, which is released by vessel entry. Coagulation inhibitors, these either circulate in plasma or are bound in endothelium and inactivate clotting factor complex. These are necessary to prevent widespread coagulation throughout the body once coagulation has been initiated. Fibrinolysis, this process ensures that excess fibrin deposition at the site of injury is either prevented or rapidly removed due to activity of the key enzyme plasma. Platelets are vital for hemostasis as they accumulate at sites of vessel injury to form the primary hemostatic plug, which is then stabilized by fibrous blood vessels, bone initiate and limit coagulation, intervascular endothelium secretes prostaglandin I2 and nitric oxide, which promotes vasodilatation and inhibits platelet aggregation, damaged endothelium releases tissue factor and prostaglandins, collagen, and 1 milligram factor, and there are inhibitors of coagulation on the endothelial surface. which are thrombomodeling, antithrombin, and protein S. The endpoint of coagulation is generation of thrombin. Thrombin generation occurs as a result of large number of enzymatic reactions, which is orchestrated by both positive and negative feedback loops. The traditional view of the blood coagulation pathway is a cascade model of reactions into stick, intrinsic and extrinsic pathway. This has now been replaced by a cellular model with three main components: initiation, amplification, propagation of clot formation. At the same time as the propagation reaction, there is continuous negative feedback from anticoagulant factors to limit the extent to which the coagulation factors remain activated. This enzymatic degradation of thrombin ensures that homeostasis is maintained at all times. The agnostic approach to effects in coagulation factors in platelet number or function or in the fibrinolytic pathway associated with the increased risk of bleeding. In contrast, effects in the naturally occurring inhibitors of coagulation of thrombin and or in the vessel wall damage from vessel catheters are associated with thrombosis. In some cases, both procoagulants and decoagulant abnormalities can occur at the same time, as seen in disseminated intravascular coagulation. Diagnostic evaluation of an infant or child for possible bleeding disorders include identify features in the clinical presentation that suggest underlying diagnosis as indicated in initial laboratory screening to determine the most likely diagnosis, the tables versus investigation to characterize a deficiency or exclude important conditions that can present with normal initial investigations, mild Wallbury-Brand disease, factor A deficiency, and basic functions disorders. These are the physical features evaluating the disorders. Age of onset neonate. In age of onset, basically is very, very important. 20% of hemophilia's bleeding occurs in the neonatal period, usually with intracranial or bleeding after circumcision. Toddler hemophilias may present when started to walk. Adolescent 1 million disease may present with hemorrhagia. Family history, family tree, detailed family tree required gender affected relatives all was suggest hemophilia. And previous surgical gender of affected relatives. Before boys, okay, bleeding history, previous surgical procedures, and dental section, if uncomplicated, suggests bleeding tendency is required rather than inherited. So, pattern of bleeding in presence of systemic disorders, drug history, anticoagulants, unusual pattern or inconsistent history, consider non-accidental injury. Pattern of bleeding, mucous membrane bleeding, and skin hemorrhage characteristic of platelet disorders or one, Willebrand disease. Bleeding disorders, bleeding into muscles into joints, characteristic of hemophilia. Scarring, delay, hemorrhage, suggestive disorders of connective tissue, Marfan syndrome, osteogenesis imperfecta or affected. 13, deficiency. Now, investigations, PT in hemophilia A is normal, 1 Willebrand disease. APTT is raised and one Willebrand raised. Normal factor 8. And SC3 hemophilia decrease are normal. 1 Willebrand antigen is normal and decrease. Activity cysteine cofactor. This is a cysteine cofactor is normal and non-Willebrand is disease. Cysteine induced platelet aggregation is normal and non-Willebrand it is abnormal. 1 Willebrand tumors are normal and Willebrand 1 Willebrand. Difference of most used initial screening are full blood count, and that's an prothrombin time test for deficiency in the intrinsic pathway in the traditional coagulation model involving 2, 5, 7, 10, and activated partial thromboplastin time APTT test for deficiency in the intrinsic pathway include